Welcome to the HQI Stopping Sepsis in Long-Term Care conference call. My name is Hilda and I will be your operator for today. At this time, all lines are open and interactive. We ask that you please keep all background noise and side conversations to a minimum. If you are not speaking, please mute and unmute your line by pressing *6, or you can use the mute button on your phone. We also ask that you do not place your line on hold as music will interrupt the conference. Please note that this conference is being recorded. And now I would like to turn the call over to Ms. Candace Hamner. Ms. Hamner, you may begin.
Hello, everyone, and welcome to today's call on how will you reduce sepsis mortality. We're very pleased to have everyone online, and if you have questions during the session, feel free to ask the question, unmute your line and ask the questions, especially when we're looking at the data, or feel free to put a question in chat. I want to first introduce our sepsis team in Maryland. This is myself, Candy Hamner, and Sheila McLean, the Vice President and Program Director for Maryland. I'd also like to let you know that Lisa Mark, the Program Improvement Consultant for Virginia, is also on the line. Our faculty today, we're really excited to have Dr. Susan Levy. She's a certified medical director. She's immediate past president of AMDA, fellow in the American Geriatric Society, and she's board certified in internal medicine and geriatric medicine. We've had Dr. Levy many times on our programs, and she is an excellent speaker, and I'm sure you'll be excited to have us take this opportunity to really look into sepsis mortality in the Maryland project. This is a very small group. We only invited the facilities that are participating in the Maryland project. At this point, I'm going to turn this over to Dr. Susan Levy.
Hi. Anyway, it's great to be here, and it's also good as Kenny and I have looked at some of the data to see some of the progress that has been made, but I think some of the lessons we seem to be learning, and she's going to review some of that, and, really try to helpfully strategize with all of you about where we need to go and moving forward, both you at the facility level and what I think, we as from HQI need to do. But just to kind of recap, and again, I think through all these webinars, you've heard a lot of the similar themes, but, CDC vital signs here basically reconfirms the fact that, as we've said many times, most sepsis starts in the community outside of the acute care hospital. So this is an opportunity for us to intervene, certainly from community patients, but in our case, particularly concerned about patients who reside in nursing homes. So we know that 90% of people who develop sepsis have some type of risk for that, and certainly that's something that I think we've talked about a lot, and I think the common pathogens. So on the next slide, I think Candy's going to advance the slides for me. We've got a recent JAMA research letter talking about sepsis and really identifying that it's a major cause for readmissions. And in fact, readmissions related to sepsis are higher than our readmissions from acute MI, COPD, pneumonia, and heart failure. Now, I know in Maryland you're more concerned about all-cause readmissions than the specific diagnoses, but I think what you're seeing here is this, again, this concept that people are coming back after admissions with other diagnoses with, actually getting readmitted to the hospital frequently with sepsis. And so we need to be concerned about that in our, particularly in our short-stay patients, but certainly in all of our patients. We know that when they come back into the hospital, particularly with sepsis, that they have long lengths of stay, and of course, they're usually expensive lengths of stay because many of these folks are requiring intensive care unit level of care for extended periods of time. And so there have actually been some recommendations that really sepsis should become a national readmission focus, and so we'll see certainly what happens. So on the next slide, I think some more facts from morbidity and mortality weekly report. Again, stuff that we know, but some more figures to put out there. 70% of cases with sepsis had a nursing home stay of greater than 2 days. Patients with a sepsis are not uncommonly discharged to nursing homes, And we also know that those patients, when they go back, frequently die during their hospital stay. So very high mortality rate with sepsis from patients who come from nursing homes. Again, they're concluding something that we've talked a lot about, which is the prevention strategy is to try to avoid developing the infections and avoid, therefore, developing sepsis. But certainly I think something we're going to talk about a little more as we go into more data is also talking about not only decreasing the number of infections, but how can you also decrease that mortality number? Can we impact that for those patients that actually do develop sepsis? So I think I have one more slide before a couple more slides before I turn it over. Again, some more of the numbers here in terms of the number of admissions from nursing homes to acute care hospital for sepsis and the high mortality. And again, some of these studies vary in the numbers, but all of these are fairly significant numbers when we talk about both the prevalence of incidence of sepsis as well as the mortality from sepsis, particularly amongst the patients we serve, those from nursing homes. And again, in this case, actually, even more patients who have sepsis being discharged to nursing facilities. So again, if somebody's been admitted to you who was in the hospital with sepsis, that again, as we've talked a lot about trying to look for these risk factors, that's a key risk factor. If you've had sepsis, the chances of having a second episode of sepsis are certainly heightened. The next slide. Again, we've talked about the high mortality rate, particularly when the patient arrives at the door with severe sepsis or septic shock. So I guess to kind of summarize, we're trying to prevent any form of sepsis. Certainly, though, if the patient is developing sepsis, we want to really try to recognize that early and get those patients moved to the appropriate level of care and not wait until they frankly are in a stage of severe sepsis or septic shock. And one of the themes that we've had, particularly from the hospitals, I think, throughout this initiative, has been that they're getting these patients too late. So one of the things we're going to be talking a little bit about or asking you all about is how can we get these patients, once we think that they're septic, to where they need to be as quickly as possible. Okay, next slide. We've talked about how difficult presentation may be in the elderly. And again, we have to have a lower threshold, higher index of suspicion, and really always ask ourselves when we see some of those triggers, could this patient be septic, or could this patient have, early sepsis? And we've talked about some of those factors that predispose the patients that we serve, including their advancing age, comorbidities, the various things that impact their ability to respond to an infection appropriately and not have this abnormal response that occurs with sepsis. The next slide. I think we're heading into some of the data.
Okay. Go ahead.
So actually, we're just kind of looking at some of the preliminary information. I think your base here for data collection was 2014. And then I think we had some data for 2016 and actually the rolling quarters, which makes it even a little more current through the first quarter of 2017. And so we use that rolling, those rolling quarters sometimes to really help us be focusing on a more recent information. So what we're seeing from the data from sepsis admissions for participating nursing homes is we do believe we're seeing a trend where there are a decrease in the number of cases that are being sent and being admitted to the hospital with sepsis. We recognize that, certainly in early, recruitment occurred in 2015. In 2016, you basically were trying to get your systems in place and do your education. And so we really do expect that it's going to be now when we're really beginning to see some impact on the development of sepsis in the nursing home patients, particularly for those of you that are participating in the initiative.
Yeah, and I'll just add here that when you look at the drop from base year to the rolling 4 quarters, which includes first quarter of 17, it's 11% drop, 65 admission drop. Which is, it's significant and exceeds our goal for this particular project.
Katie, I think I got a little out of order there. So do you want to go ahead and talk a little more about the data?
Yeah.
I think you referred to the one slide there already.
I'll go ahead and go on to the data, but certainly just interact. If any of you have questions, ask the questions as we're going along and hello? Are we okay?
Yeah, I can hear you.
Okay. These particular slides that you have in front of you, this looks at admissions from our participating nursing homes. The data you saw actually in a chart on the previous slide, this is now in a graph form, and also all-cause admissions to hospitals. One of the things that we've seen in this project is that both of those numbers have decreased. Now, these include readmissions. This would be admissions, whether it's a new admission from your facility to a hospital or readmission, a resident who came from the hospital and went back. But what we're seeing is that all-cause readmissions dropped 15%, while our sepsis has dropped 11%. So you're seeing a good decrease in both of those areas. And here's some of the conclusions we've looked at in looking at the sepsis data. And pardon the typo, it should be admissions, not readmissions. This admissions includes readmissions, but it's all admissions. What we've seen is we've had a significant decline from the baseline, but not as much as the all-cause, which what lets us know is that there's a lot of effort being concerted across the nursing homes and the acute hospitals to reduce readmissions in general and hospital admissions from nursing homes. We've seen, obviously, much better improvement over the last 3 or 4 quarters, and I expect we'll see even better improvement with the second quarter of 17, which will be the last data we'll see from this particular project, and that should be out in the next couple of weeks. What we're seeing, a lot better decline, more significant movement, and it matches the interventions, which if you go back and look at the charts that we have some lines that show you where we began some of our interventions. Not all facilities have demonstrated the same level of improvement, and we are certainly talking with those facilities that are still struggling to see what we can do to improve the interventions they have put in place. The big thing we wanted to talk about today was mortality. And while mortality is not the goal of this particular project, it was to reduce admissions, we felt that we would see a connection between reducing admissions and reducing mortality. And we're not seeing that. What we're seeing is that the mortality rate is pretty much staying the same. And that is giving us the impression that we are probably doing a better job in the nursing home of identifying infections, potential sepsis, and putting some measures and actions and interventions in place. But once we recognize someone needs to go to the acute hospital, there seems to be obstacles in getting those residents to the acute hospitals and or getting the interventions they need started in the facility while you're waiting to get them transferred. And what you see on this particular chart, too, the yellow is Maryland. It's showing you what the number of transfers to nursing homes that die. Now, what you're looking at here, the numerator are the number of beneficiaries, Medicare beneficiaries who expired in the hospital. The denominator is the number of admissions. So, yes, a particular resident could be admitted a couple of times or go to the ER and come back a couple of times, and that would be counted in this particular one. But what it shows you is the rate has essentially not changed. This next one is based solely on beneficiaries, so it doesn't matter how many times the beneficiary went to the hospital, it's counted once. So this looks at mortality by beneficiary, and it's very similar to the graph we saw before. You're not seeing really any change, and again, no significant change, actually a little bit of an upward tick in mortality. So what are we seeing here? I think I just mentioned some of this stuff, is we're not seeing a significant change in mortality. And that's something we really need to look at, and as facilities look at why are we not seeing, a drop in mortality when we're seeing a drop in admissions for sepsis. And again, we think a lot of this has to do with early recognition of it, as well as early intervention, and then timeliness of the decision to transfer. We were at a forum recently where one of the facilities talked about the difficulty of getting an ambulance in timely to get a resident transferred to an acute care, and that they couldn't always get the 911 operators. I know that MIMS has just put in some criteria now for making sepsis a priority. If you call 911, it's important that you have that information, you've gone over it, and you know what you need to say to 911 when you call, so they understand that this is sepsis and they are to get there quickly and make sure that resident gets transferred. So what can we do to tackle some of these issues? We need to do a root cause analysis of the problem. Sometimes what we tend to do is we tend to look at a chart and say, well, that resident was really sick, they needed to go, and we don't really stop and look back at the big picture. We don't analyze our data and go into the chart and say, how long did it take for us to recognize sepsis in this case? Should we have recognized it a little bit earlier? Once we made the decision to transfer, and actually in that, how long did it take to recognize also means when did the nurse call the practitioner, give them the information, and the decision was made to transfer. But once that decision was made, did you get an ambulance timely? Was there a delay? And what time did they actually arrive in the emergency department? We know time is tissue. We've talked about that a zillion times. And in a resident who's in septic shock, every hour they go without an antibiotic, their chances of mortality, of dying, increase 8% per hour. Well, and I just already said that. I'm getting ahead of myself. Time is tissue. And just said that. Delays in transfer can take a resident from early sepsis to severe sepsis in just a matter of a couple of hours. And in a nursing home, at least in my experience in a nursing home, we didn't want to act hastily or too quickly. You want to take time to make sure what's happening with residents, and some of these symptoms are vague and you're not sure which direction you're going in. And sometimes we take too long to actually make that decision and then start that transfer. But if you have to wait for an ambulance or there's a delay in getting someone there, is your facility able to start the fluids and begin the treatment? Many times, just being able to give a bolus of IV fluids can make a huge difference. And now those MIMS criteria do say that the ambulance drivers, if it's sepsis, will start the IV fluids. Another thing is in nursing homes, we don't necessarily practice rapid response teams or anything like that. But maybe we need to think about a rapid response model where you practice a little bit that when you think someone's going south with their sepsis, that you have something in place that you all do. People have certain steps that they follow. The chart review. I know everybody looks at the return to the hospital or the send out. But it should be done not just by one person in your quality department, but through a team approach. And again, the answer isn't, yes, they were sick, because we know they were sick. You're smart enough to not be sending people out if they're not sick. But going back and saying, what have we in place that might have prevented them from getting sepsis? The reality is, in the nursing home environment, most facilities don't have the capabilities to treat that resident once they're heading into severe sepsis. Your best bang for your buck is going to be identifying the infection, treating the infection, and preventing the sepsis from occurring. You want to look at what could you have done differently, where are there delays, and how rapid was the rapid response? Again, that time from A, you noticed that the resident needed to go to the hospital. When did they get there?
Okay, I think we're going to try to go ahead, Candy.
I'm turning it back over to Dr. Levy.
I think, before we go into some of these questions, I just kind of want to comment, because I think the men stuff is particularly important. And I look back historically in my own career, and over many years, and some of the lessons we've learned that have made a tremendous impact on patients surviving. I mean, certainly, those with Maryland backgrounds and the shock trauma and the whole men's issue, know the importance of being taught that it was critical that we got trauma patients to these trauma centers within an hour, and we really could save lives. Likewise, we all know with the magic word chest pain, how that gets everybody moving quickly. More recently, stroke, as we now have better interventions if we are able to utilize those rapidly, that really can increase survivability. And so now I think what we're learning is that we need that key word of sepsis, so that when you're talking to the 911 operators, they understand what that means and how important it's going to make sure that those patients are certainly at the highest triage. So I think, again, sometimes the key words that we need to use to get people's attention. And frankly, that's all part of, if you go back into even like SBAR communication, it's all about using language that really will get people's attention about how serious the situation is and how I need to really, bump this up. And so I think when we talk about the mortality issue, and I know there's pressures. I mean, certainly we all know there's pressures to avoid transferring patients to the hospital. But once we've identified that we think a patient is septic, that patient needs to go, and we should not be spending a lot of time trying to do interventions unless at the same time we have triggered that 911 system. Again, you do CPR, but you're triggering 911. Think of these, how we can take these same lessons from other acute conditions in our facilities and transfer them, to this condition, to sepsis. So, again, throwing out some questions. So we would like to see something in chat rooms or getting some conversation going and getting some engagement. And, I kind of divided these questions in a little bit. I think some of you were able to ahead of time. But first, not to forget that, again, we don't have to worry about mortality if we never do have the sepsis developed to begin with. So really just trying to get some feedback from all of you, if some of you would volunteer make some comments about what you've been doing. I mean, we know looking at the data that some facilities seem to be having more impact than other facilities on decreasing the number of patients they're sending out with sepsis. So what's your gut at this point? Because you have more current data, most likely. Can we hear from some of you about whether you feel from this initiative you're sending less patients out to the hospital who are ending up being diagnosed as septic?
And then you're fine.
You got a volunteer? Yes, no? So, how about education? Have you all actually done any staff-wide education? Or have you done anything with your patient family education about sepsis? And we've been giving a lot of tools out. Can somebody tell us what they've actually done in their facility?
The lines are open, so the lines are open. You just have to unmute, and you can.
Go ahead.
Donna Wilhelm.
Hey, Donna.
Hi, Donna.
Hi. I just wanted to let you know that I believe that the staff I was trying to type it in chat, but I thought since no one was talking, it'd be quicker to speak with you. I think the staff are much more astute at recognizing sepsis early on now, and I think we are seeing a reduction in the number of residents going to the hospital for that reason. We did indeed use the toolkit at Longview, the 100, and we also had someone come from outside and do an education very similar to that. So I think all of that was very helpful. And
good.
I think it's been an important part of our infection. It's an important part of our infection control.
Sure.
Mm-hmm. Yeah.
So do you use the toolkit? So you're using the 100 cards or posters or?
Yes, we did both. We did an education initially after getting the kit.
Okay. Anybody else or any feedback on the kit from anybody? Thanks, Donna. I appreciate that. How about, because I don't know if you feel anything, have you been able to do anything with patients and families yet? Because they often can be the key to picking up some of those subtle changes.
Well, I think the biggest risk with our families are that, trying to work between and a hindrance in some manners is our, antibiotic stewardship program. You're trying to avoid the use of antibiotics, so it's a catch-22 because you're working between waiting those 2 to 3 days to get a culture back or a chest x-ray or whatever you're, looking for, and someone who is in the beginning stages who lots of times that 100 isn't getting up there until they're more sick. So, and then you have families who still aren't on board with the antibiotic stewardship program. They think that you ought to give an antibiotic more often than we are. So that's a continual education piece that we try to do through resident council and flyers and try to encourage our families to understand that bigger picture. But then they'll call the physician and the physician will go ahead and order an antibiotic. So that, and then of course you have the 48 or 72 hours when you're trying to reeval and get that antibiotic stopped if it's truly not necessary.
Okay. Do you, and I know we're all still early in this and all the new regulations and guidance, also just as a practitioner, just encouraging you to, kind of engage your medical directors and your practitioners and make sure that they've also received, received education. I mean, certainly when we talk about antibiotic stewardship, it's part of what's in the guideline is demonstrating that you've done some, practitioner education around the importance of it, with the goal to, really be giving them feedback when they're, when they're ordering antibiotics when they shouldn't be. I know these are all difficult initiatives. I mean, we just want everybody to do everything right all the time. It is a bit of a balancing act. So, but it sounds like you feel that you're having less patients actually going out and ending up in the hospital. Yeah. Anybody else?
That's correct.
Okay. Anybody else? Or? Okay. Well, I appreciate your, your comments, Donna. Or can I ask if anybody want to speak up in their QA meetings? Is this a project they're looking at? I think that's really the
kind of awfully shy group here. Normally we get the group talking a little bit.
Okay, well let's go maybe to the next set of questions. Which is the readmission review.
Okay.
Okay, so now we want to hear from everybody. Is everybody reviewing their readmission? Or their hospital transfers? Which actually you should be doing both, and I know we get this confused. Our focus for a number of reasons are on the short-term readmissions of our short-stay patients, but frankly you should be looking at everybody who goes out to the emergency room or hospital. About whether that was appropriate, did we really, intervene early, diagnose early. So, any comments on how you're handling your readmission review? So, no one's doing readmission reviews?
Oh, they are. Come on. Some of you out there say something. Don't be so shy. So we're just, how can we bring it back if you all don't talk?
Right. Certainly it's
I know all.
And I'm running into the same issue because I'll get to one facility and I'll be like, oh, we already looked at the readmissions. Well, you didn't really look at them as a team. It'll be the DON said she looked, or the administrator will say they looked. But really to have, I think the most benefit is you need to be doing it as a team, and you certainly need to engage both the practitioners, because what you want to find out is what were they thinking, what was their thought process, with the residents, as well as the facility medical director. So, is that occurring, and how often is that occurring? Are you doing it every week? Are you including it? If you're including it in report, I'm sure you discuss it there, but are you really then able to truly get the team think around it?
Well, I know at Longview, where the ADON and the DON meet with the medical director weekly, and they review that information. They review hospital transfers and readmissions, because we're looking for, one, was the transfer appropriate to begin with, and could the person have been treated in facility rather than a transfer, and then two, on readmission, what did we miss when we sent them, what could we have done earlier on to have prevented that admission from occurring? And then they present that information monthly to the QAPI team so that the QAPI team can review it. And I know other Aurora facilities are doing the same thing. They're also reviewing all that information and bringing it to the QAPI team. So I don't know exactly what their format is, but I know those facilities are indeed doing that.
So are you finding opportunities to intervene, particularly as it relates to this infection?
Pardon?
Are you seeing opportunities when you're doing these reviews, particularly related to infections? Anything that you've identified that you think you're now doing differently that's helping either prevent infections or get patients who might be septic out earlier, or?
Well, I think the education that we did early on, and that's probably been, back in February, I think, when you sent those kits out, I think all of that has made a tremendous difference in the knowledge of the nurses on the floor, and, you try to work within that 24-hour guideline when you see a patient having significant change of some sort, and it may be minimal at that time, trying to do all the things in-house to evaluate that, to make a determination of which direction that you need to go. I think facilities have done a much better job of trying to cope with those issues and deal with them when they can get hold of the primary physician, because once you get into those evening hours after 6 p.m. till 6 a.m. when you have a on-call physician available, unfortunately, many times you're going to get a transfer to the hospital because they don't know the patient, and, they're questioning, they don't know the nurse that they're speaking to and whether or not the information, how valid that is. And, of course, if they're a, full code and transfer to the hospital, they're typically going to take that route. So I think facilities have done better about managing the whole situation. And if a person starts going bad in the evening, they're looking at that, early in the morning to try to get that addressed. And I think that's had a lot to do with our decrease in the number of maybe unnecessary admissions to the ER and hospital.
I have a question here, and I think this is something that Dr. Levy, you brought up from some of the readings you've been through, is that one of the things we're finding is that a patient comes from an acute facility, say they had a stroke or had a surgical procedure, and they come into the nursing home, but they're a readmission, but their readmission is for sepsis. It's not for what they came in for. It's not that we're not seeing a patient who's had an infection or sepsis come in and go out for sepsis, but we're seeing an awful lot of people come in with other diagnoses and going back to the acute hospital with sepsis. Are you finding that you're seeing more of that? Are you finding you're able to intervene to prevent some of those infections? I don't know, Dr. Levy, if you want to comment on that.
Yeah, I mean, I think this is the whole, concept that just being sick and in the hospital and having an exacerbation of an acute illness, of a chronic illness, or another acute illness that led to an initial hospitalization, does something to you to make you at higher risk for a subsequent infection. And so I think we are doing a much better job with a lot of the common diagnoses like heart failure in managing those patients in the nursing homes, assuming it's not related to their underlying disease. I mean, I think we're doing a better job with weighing patients and identifying changes in weight, but are we also recognizing that what they may be going back for is actually infections are higher risk for that? So it's really kind of risk assessment for infection. The other thing I'd like some feedback on, and I know we've got a fly crowd here, is that, are your area hospitals? I know, everybody's looking at preferred health networks and putting together groups and meetings between the nursing homes and your local referring hospitals. Are the hospitals jointly looking at some of these cases with you that are readmitted? I mean, are you getting kind of joint feedback? So do you really know that know what that patient went out with and know that timely? So that you're looking, again, both of you are looking at that transition and seeing what could have been done better when they're going back.
Well, I know that we speak to our hospital liaison monthly, and we speak to the number of transfers we've had out, how many of them were within that 30-day window. The hospital's looking to see from us, how they could have assisted us in keeping the patient there so the person didn't come back within the 30 days. So I think because of that 30-day readmission issue that we've been more receptive, the hospital's been more receptive to working with us to see, especially your local hospitals who are your major transferring facilities, and trying to provide programs and things that will assist you in maintaining the resident in your facility if at all possible. So I do think that has greatly improved over the last year in comparison to prior to.
Okay. So there really is better collaboration, and I'm going to assume some of that applies certainly to sepsis. Well, I guess, we can go on to the next slide with some questions, and maybe somebody will I think, Donnie, you already indicated that you're doing this, but, we're reaching the kind of end of November date when we're going to be looking at our facility assessment plans and our infection control plans. Have you really, since you've joined this initiative, is this something you're really including in your quality plan? Do you have it set up as a formal PIP for sepsis? So can we hear from some of you about how you're handling this through your quality committees and if you've got any feedback on that or if that's working? And Donna, we already heard you are, so I don't know if there's anybody else out there, or if somebody doesn't want to speak up, if they can write us a little chat. Okay, I mean, because part of it is if you really are doing this work, around trying to decrease sepsis and also, improve mortality from sepsis, you really should kind of be taking credit for it. If you're really giving it the effort that you should be if you're engaged in a collaborative. This is a natural kind of program that you can do this with. So whether you really are looking internally at your own rates and tracking those.
Then I just remind people that if you did that infection prevention assessment that's done online, if you did that, we can send that back to you in a PDF form, and you've got that as your infection prevention program assessment. You'll need to address any areas where you have no's or I don't know, but you can use that tool. So if anyone wants that or needs it, or even if you haven't done it yet, you want to do it now, do it. I'll download it and send it back to you. But you can use that, and all of this is great for your cropping plan. I mean, so much has been done that you really should get credit for it. Well, I guess we're hopefully...
Yeah, I mean, I was just going to say, also, likewise, those that, I know there are some people who participate in this initiative because they had very high sepsis rates. If that's one of their lead diagnoses, again, that should be included in your facility assessment and how you're looking at if this is a diagnosis that you have a problem with, and your facility assessment should be addressing that. So all of this should really, you should start, I think as you've pointed out a lot of times, you should start connecting the dots on all of these initiatives.
All right. We'll go on down here to the mortality question.
So we talked a little bit about, I know we got feedback from Donna, we haven't heard from others of you about whether you feel you're getting to patients sooner. Certainly the data overall we're seeing seems to think that, the mortality rates really haven't changed. And if we really were identifying patients sooner, we would hopefully see a decline in the mortality rates in those that actually do end up going out with sepsis. But, I don't know if any of you have taken on looking at things like a rapid response process. Are you looking at your, one of the things I run into is I'm trying to figure out how many pieces of paper the nursing staff has to complete before the patient actually gets out the door. Are we really, I've seen places where there's a progress note, there's a change in condition form, there's a transfer form. Are we really making sure that we're putting systems in place that when we realize a patient needs to go, that they go, and that we don't delay? So any feedback from people who maybe are trying to look at how we get people out sooner? Or what some of your obstacles may be? Is it 911? Is it, people not calling back? Do you need to have people call back when the patient's out acute?
I found it distressing to hear that some facilities were having issues getting 911 to come to their facility when they were having an acute problem like that. That's something I've not experienced, so I thought that was very worrisome.
Okay. Yeah, I agree. We were surprised when we heard that they were going through, and I'm trying to remember the exact stuff, but it was having to call various private ambulances to get someone to pick them up. Again, it may have been teaching them and the education coming down from them just to what to say on the phone so that 911 understands this is sepsis, this is an emergency, you need to come.
Right.
And that's something we actually, through our care transition program, we're going to be pushing this information out to the areas that have these questions and make sure they have a good understanding of what the 911 operators and ambulance crews are supposed to do. I think it's important. I do think it's important to track your mortality and really look at when a resident goes out and dies in the hospital, they went out with sepsis and dies, is really to go back and be thinking about what we could have done sooner with that resident. But it isn't, not just beating yourself up about what could you all have done, recognized earlier. You may have recognized it timely, but there were obstacles. It's getting is it getting a lab result back? Is it getting someone to start the fluids? Is it getting to the physician? Is it getting the ambulance? What are the things that made that take too long and the resident arrived at too late of a stage? It's really an important thing to look at.
And so the key is making sure, it may be useful to look at how are you sending out your patients that end up arriving in the emergency room with a diagnosis of sepsis? And frankly, they shouldn't be going out. They should be going out 911 transport. They should really not be going out. Even though I know over the years 911 has often tried to push nursing homes to not use 911 as much as they have, sometimes because, concerns of overusing it. But, frequently, as we are sending less patients out who don't have serious acute needs, frankly, we probably should be using 911 almost more, because those are the types of patients that we now are sending to hospitals. So, right. I think certainly looking at that, and if you're getting some pushback, needing to follow up with them, and I do think a lot of it's about the language you use, and what your staff may be saying to the ambulance operators.
Right.
I think it's also important to do some trending to find out when the person's going out. If they're going out on, Sundays and Mondays, were we missing the boat on Friday and Saturday? And I think that sometimes that gets lost in the shuffle. That's part of that weekly review.
Yeah, that's a good point. Very good point.
Good point. I know in my one facility a while ago, we used to find out that most people went out on Monday, which means to me we were probably trying to sit on people over the weekend that really should have probably been sent out sooner.
Well, or did we have the staff on who were really able to recognize the impending situation, that they thought that it was safe to sit on, but, maybe they didn't recognize enough signs and symptoms. If they would have called the on-call physician, more than likely they would have been sent out. So, it's difficult, and each situation is different. That's why you really need to look at each individual situation to determine, because there's times when no matter what you can do, that was the outcome. So, everyone did the best they could do. So, but we want to support our staff when they made the right decisions and educate our staff when we feel like we could have done something a little different.
Good. Good comments. Good comments. All right. Do you have any more questions, or is this the end of our questions? Yes. We are going to open up for just general Q&A in just a second. Again, you can put in chat, or you can certainly, you've got open lines. I just want to remind everybody, we have a resource center now at HQI. It's very simple. It's www.hqi.solutions/resource-center. And on that, at that center, you can get recordings of these, of the webinars. You can get copies of the different resources, the things that were in our toolkit. There's a lot of, there's links to stuff on CDC and other places. So it's really a good place to go to get additional information. If you have questions or concerns, or you didn't want to comment in front of all these people, there's not a large crowd here, but if you didn't want to, you can email me or call me, and I'm happy to follow up on anything you would like me to look at. We're going to open this up for the next couple of minutes and see if anybody has any questions on anything.
The only thing that, that I'm trying to work on our antibiotic stewardship program with the antibiotic surveillance and all those pieces. And the new regulations, are looking at wanting written policies and procedures in regards to antibiotic use and dosage and duration. And I've been trying to find locations that would give me good examples of, I even spoke with our one medical director, and he didn't have a resource. I looked on the FDA page has about, safety of medications and has about the quinolones. And right now in our facility, we're doing a risk-benefit statement on the quinolones because that's the highest risk for C. diff and that type of thing. But other antibiotics, we're not necessarily doing a risk-benefit statement for them on. But, I've had trouble finding a resource that gave those actual indications. I did find one, and that was by KSLA Public Health.ca. That's the only one I've been able to find. That's the website that I've been able to find any guidelines for the actual antibiotics, like, UTIs, pneumonias, what to start with, but I would have thought that information would have been in various places. The McGreer's and the Loeb infection criteria, they give you the criteria to have before starting antibiotics, but they really don't lay out the mannerism in which to give the medication. So, and those new policies are actually asking for written policies and procedures. So this is the only form I've been able to find, and it's actually a really pretty good one. But, I went under the Institute for Safety, ISMP and FDA and Googled everything I could find. And I've been, working for several days trying to find just good resources. And honestly, that's the only one that I've been able to find. So if you all have any knowledge of
who's your pharmacy provider? So this is something where you're consulting.
Remedy's our pharmacy provider, and Remedy does a great job. I'm not, but I don't know that they have an actual page that says when to give for what, for how long and that type of thing.
Okay,
I can check with Bill
I do, because I know, I just really saw some stuff come out of one of the other major pharma companies that really provides you, what you want is essentially a list of recommended treatment, including which antibiotics and duration. And that is, your pharmacy should be able to provide that for you. And then you would adjust that over time based on looking at, for example, your local infection pattern. We don't expect anybody to start with all this information. So over the next year, as you're looking at your infection control plan, you're going to see, so what are my antibiograms? What kind of bugs am I growing? What is their site? What is the types of bugs? And then if there's resistance issues, I may adjust, my preferred treatments based on that. So I can almost guarantee you that they do. I know that the American Society of Consultant Pharmacists put out a toolkit. I believe included in there are some suggested regimens. And actually your medical director should be able to do that for you based on, their knowledge of what are the types of things that you use to treat various infections. I will generally tell you that most people are saying 3 to 5 days for uncomplicated UTIs, longer for complicated UTIs, and similarly, probably 5 to 7 days for pneumonias. But, that information is available to you. I would get on the phone with your consultant pharmacist, and because they are supposed to be engaged in that. If you look at right.
Absolutely.
And so I suspect Remedy has something, or very quickly will have something if they don't. I don't know if any of the others on the phone are using other pharma providers and if they've got resources. Your colleagues aren't helping you. They're leaving you out there. You really should be able to get that. But yes, there are some other resources that physicians have used over the years. There's something called the Sanford Guide, although that's a little more used for hospitals for patients coming in. It's similar, and I think it does have categories for patients coming from, other institutional settings. So that's probably one of the classic ones that's been out for years, the Sanford Guide. Whether that's totally been updated with all the duration recommendations, I'd have to see, but that is another resource.
Okay, and I have a white paper from the American Nurses Association. And CDC. I'll look through it and see what recommendations are on, and I can send that to you as well. I'm not sure how specific it is. I just printed it out recently and haven't read it yet, but I'll forward it to you if there's anything.
Right, we're just trying to, trying to get the best, I think a lot of the, best plan is just to, develop a protocol for your facility, not to order any antibiotics greater than 3 days to start with, and then have it reevaluated in that time frame because then your lab's back and all that. So if you develop a protocol like that, then you should be able to, not miss doses, continue if needed, or change medication, or get rid of it within 3 days if you really don't need it.
Right.
See, and that works very well with sepsis too.
Right.
Absolutely.
Started carefully and then back off. Right.
Right.
Well, that's why I'm saying that. That's why I'm saying that, you know, sepsis falls in underneath our whole infection control program.
Right.
And, you know, this, you know, antibiotic stewardship we've really been doing for some time because we're looking at all of this, but it's just in a more formal setting now that you have to have it all laid out so that, you know, that it's clear what you're doing and what your process is.
Yes. Very good. Any other questions before we come to a close here? Well, I hope you all have found this valuable. I don't know if we have a evaluation that can be posted to the website right now. Do we have one, Ventec, that can be posted, an evaluation?
Well, I'd like to take the opportunity to thank you all for all your work because it really is very helpful and, you know, you can give people information and unfortunately you can't make them use it. They have to utilize it at their own will. But having the availability of these resources close by is really valuable to those of us who are really looking to make a difference.
Well, thank you. We appreciate that. All right. Well, I think we've come to a close, and thank everyone for attending. And any comments, any concerns, please feel free to give me a call or shoot me an email. Thank you.
Thank you.
Thank you.
Bye-bye.
Ladies and gentlemen, this concludes today's conference. Thank you for participating. You may now disconnect.